Good afternoon, everyone. We want to thank you all for coming this afternoon, and we'll give you all a moment to get settled into your virtual room, and we will start promptly at the hour.
Recording in progress.
Good afternoon. We want to thank you for taking time out of your busy day to join 7-Star Academy in partnership with the ALLofUS Research Program, LSU Health Sciences Center, the Alpha Beta Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and DePaul Community Healthcare Centers in this conversation about my ancestry, my heart, and the ALLofUS Research Program. It is my pleasure to serve as the moderator for this event. I am Dr. Kitani Lemieux. I'm a principal with 7-Star Academy, and I'm also an associate professor in the College of Pharmacy at Xavier University. It is my great pleasure to speak with you this afternoon. I'll ask you to advance to the next slide, please. We'll take a moment if we could get you all to using your phone or another device to capture this QR code. If you would just take this quick pre-test for those of you who are on your phone or you don't have that ability, that link is in the chat for this pre-test. And we would, as you complete that, mention that you heard about the ALLofUS Research Program from 7-Star Academy. It's 5 questions for the most part. It's 8 if you're a provider. So we thank you in advance for your participation in our audience survey. Before we go to the next slide. Next slide, please. So we want to share this disclaimer. 7-Star Academy Incorporated, nor the participants in this educational seminar do not provide medical advice, nor is this presentation intended to be a substitute for professional medical advice, diagnosis, or treatment. Seek medical advice from your healthcare provider. Next slide. So let's talk about the precision medicine program. Next slide. So let's watch this video. Excuse me, I don't have the sound yet. I think we can hear it. We don't see the video playing.
Meet Ray. Ray lives on a farm. He loves playing kickball with his grandkids, but lately he's gotten a little slower and been visiting the doctor a lot more often.
Video stopped short.
This is Kim. Kim lives in the city. She loves to exercise, cook healthy meals, and can't remember the last time she called in sick. They're both people, but not all people are the same. And yet, when we visit the doctor, our treatments don't look that different. Why is that? Because we just don't have enough information to do it better until now. Enter ALLofUS, the research program based on precision medicine. Precision medicine is a revolutionary new approach to treating and preventing disease that's personalized instead of one size fits all. By gathering health data from 1 million people like Ray and Kim and Trevor and Samir, our country's best researchers will be able to develop treatments that are as unique and complex as we are. With this new information, doctors will have a better understanding of disease so they can innovate the next great breakthroughs in medicine. Once enough people join, suddenly everything changes. Information becomes clear, patterns emerge, and simple data transforms into life-saving knowledge. This means that Ray and Kim's children and their children's children can live longer, healthier lives. By becoming one of the first 1 million people to volunteer, you can help reshape the entire future of healthcare for generations to come. If we can figure out how to fly, put a man on the moon, and connect the entire world, surely we should be able to improve the future of healthcare. Not just for Ray and Kim or even you, but for all of us. Sign up at joinallofus.org. The future of health begins with you. Meet Ray.
Thank you. So now that we've seen the video, let's talk a little bit about precision medicine. Precision medicine is an emergent approach to actually address overall, not just disease, but also health. And specifically, the approach that's being taken is not looking just at the biology of a particular patient, but also the lifestyle and the environment. Well, what does that mean? Lifestyle. Do you get in 10,000 steps a day and drink 8 glasses of water? And with respect to your environment, do you live near green space, or do you live more towards near a body of water, or do you live closer to a railroad track? So these three components shape one's overall health and wellness. And so this is a radical shift from the traditional one-size-fits-all medical approach, where we just look at one dimension that would typically be biology and just make healthcare decisions based upon a one-size-fits-all approach, and everyone gets, if they present in a similar fashion, they all get the same treatment. And we now better understand there are other factors that shape one's health. Next slide. So all of us have experienced, or most of us, dare I say, have experienced precision medicine in some form. If you wear eyeglasses, or if you know someone who does, that is prescription eyeglasses, where you don't just grab a pair off the shelf, but those glasses that are made uniquely for your vision. Also for insulin pumps, those who have need of an insulin pump, everyone doesn't get the same dose. The insulin pump recognizes the blood glucose levels of that particular patient and releases insulin accordingly. With respect to blood transfusions, we don't all have the same blood type. We know that patients have to be typed to receive blood or blood products. So there's specificity in blood types. And lastly, with hearing aids, that's another example. Folks who need to be fitted with hearing aids do so with not just being properly fitted, but also with respect to how well or how poorly they hear and the decibels that are needed to improve their hearing. Next slide. So the types of, generally speaking, the types of research questions or even clinical questions that could be answered if we looked at 1 million people, which is what this precision medicine program seeks to do, is to recruit 1 million people to be participants. And what kind of questions would be answered potentially? Chronic pain. Chronic pain impacts a number of people. Dementia. We have populations that are living longer. So how do we, if not stop or slow the progression of dementia? Can we develop medications that are not addictive? Can we come up with treatments that prevent diabetes? Can we skip painful trial and error chemotherapeutic approaches? These and many other questions. And then another questions, or do we drive sustainable interventions that support health equity? Is there one group that benefits from precision medicine more than another? Or will the implementation or the full implementation of precision medicine leave people behind? That is in part what we want to talk about today. Next slide. So an overview of the ALLofUS research program. Next. This program began in 2018, May of 2018, when it actually began to onboard and enroll the first participants. Was really and came under the guidance and the directorship of Dr. Francis Collins, who recently retired as the director of the National Institutes of Health, where this initiative is a longitudinal study. So is this a short term? It's a long-term initiative to gather data from 1 million or more people living in the United States to accelerate research, and taking into account the individual differences in lifestyle, socioeconomics, environment, and biology. Researchers can now seek to deliver precision medicine. Really, medicine that shapes you. Individualized prevention, treatment, and care for all of us. That is the goal of the ALLofUS research program, is to better understand the individual's health so that one can improve and help manage one's health, and also provide a better or an improved quality of life. Next slide. So the value. So not only will this data set be developed, it would be an asset. It would be a research asset for the clinical and research faculty to follow participants as they move through age, develop relationships, get sick, or stay well. So it's not just about what gets people, causes people to be sick, but also what keeps people well. So this is a longitudinal data set, so one can actually follow the data over a period of time. And it extends in time and helps scientists develop long-term treatments. So how do we find new targets for therapeutic intervention for cancer or for diabetes or for various inflammatory disorders, lupus, and diseases that tend to plague some communities more so than others? How do we begin to better understand that? And we have a data set where we can actually screen to help identify and select or filter these data out. That becomes important. because once you have the data set, and being a data set, it then allows us to remove bias from the data, where it's not about an individual person, how he or she may present, but as the data lead and guide. So discovery will be made by and allowing us to remove data in the process. Next slide. So this transformational approach is really emphasizing the rich diversity that our country has amongst the people, health status. They want folks who are sick or people who are well, data types, and demographically from all over the country. So the goal of the ALLofUS research program is to be representative of the people who are in this nation. And with that in mind, the goal is to have 70% or better diversity in this data set when it speaks to ethnicity and or gender or race. So across the board, all of these things, they want 70% diversity at every level. Next slide. And as we speak to underrepresented and biomedical research populations, we'll also acknowledge that February is also Black History Month. And so that being said, traditionally, African Americans have been not necessarily left out of biomedical research, but not in a productive way. And so now this is an opportunity with many missteps in past for us to, in a robust and with an informed consent fashion and with a responsible way where participants are not viewed as patients, but as partners in the process. Underrepresented in biomedical research populations are strongly encouraged to consider participating in the ALLofUS research program to lend to the data set, to improve health outcomes for each of the communities that have been underrepresented in biomedical research. It's really important to mention that if there's not enough participation, then all groups will not or may not benefit from the promise of precision medicine. Next slide. Again, we said it's a transformational approach to accounting for one's overall health in the data that are collected, the lab analyses that are done, research that will be conducted, but also data is returned to the participant. Well, what does that mean? Participants will actually receive information back as it relates to their overall health and wellness, their genomic information. All of that will be provided back to the participant. Next slide. Yes, and the data are secure. There are a number of levels of ensure the privacy and security of participant data. There are a number of levels of how the data are managed and secured, and so it's very tightly regulated. And we can talk more about that, but it is a high level of security, and we can learn more about that at the website a little bit later. Next slide. Next slide. Next slide. All right, so we mentioned the value to our patient, to the participants, that they do get their data back. And also you contribute to not just to benefit you, but your children and your children's children, because this data will be readily available and will benefit and enhance discovery for years to come. Next slide. Next slide. Okay. Enrolling in the ALLofUS research program. There are several partners here in the New Orleans area that are depicted here on the screen that are participating in educating the community about the ALLofUS research program. And so 7-Star Academy, along with a number of the other organizations, academic institutions and organizations listed here, are also participating in that initiative. Next slide. Next slide. Okay, and what to expect when one enrolls. I'll let Dr. Milay talk about that a little later. Next slide. And there are 2 enrollment sites in the city of New Orleans if one chooses to participate. Again, Dr. Milay will talk about that. Milay will talk about that. Next slide. Next slide. All right. So there are 3 key takeaways I wanted you all to know about. Precision medicine is individualized prevention, treatment, and care. It is a longitudinal study that will continue to be a research asset and tool over generations to come. And participants are treated as true partners whose data will be safeguarded. And so with that, I'm going to ask that we unshare the screen. And I am going to invite 2 of my colleagues to join me in this conversation. Dr. Ashley Taylor is a colleague and assistant professor in the College of Pharmacy. And I'll ask that she introduce herself at this time.
Thank you, Dr. Lemieux. So I've been a faculty member in Xavier's College of Pharmacy since 2008. I work in the Division of Clinical and Administrative Sciences. As a clinical pharmacist, I've practiced a little over 15 years in this area of cardiology. I've worked in the hypertension clinic, the anticoagulation clinic, diabetes clinic, primary care clinic at University Medical Center in New Orleans. And currently I'm working at the endocrine clinic in the VA hospital in New Orleans. And there I'm seeing patients who have uncontrolled diabetes and patients who are dealing with obesity.
Thank you, Dr. Taylor. And Dr. Gillard, if you would introduce yourself.
Hi, good afternoon. Again, Christopher Gillard, Clinical Associate Professor at Xavier College of Pharmacy. I've been here teaching about 9 years and also have a clinical practice in acute care, internal medicine at University Medical Center. And the disease states I mostly manage are cardiovascular disease states, including hypertension, heart failure, cardiac arrhythmias, venous thromboembolism or blood clots, and also some other acute care disease states I may see in my practice. So nice to meet everyone.
Thank you both. And so given that we're in heart health and really want to have an emphasis on heart health and diseases associated with the heart, Dr. Gillard, I'll come to you first. Can you tell us a little bit about the big diseases that you see relative to heart health and kind of give us some differences that are associated with each?
Sure. Well, there is still a pretty significant burden of cardiovascular disease in the United States. I see a pretty broad spectrum. Hypertension is still very common in the United States, where we have more than 40 million people in the United States that have hypertension that continues to grow every year. It counts for a lot of different physician visits annually and also leads to a lot of cases of hypertensive crisis. Also, coronary heart disease or disease that leads to myocardial infarction or heart attack is very common. Coronary heart disease is the leading cause of death attributable to cardiovascular disease. Also, stroke and also heart failure are very common cardiovascular disease states I see in my practice and are very common in the United States today.
So thank you for that, Dr. Gillard. So are there typical approaches that you see with heart disease demographically, ethnic? Are there differences in how patients are treated across the different ethnic groups in your practice?
Sure, there definitely are. There are differences in how hypertension is in different ethnicities. For example, in African Americans, all African Americans, about 40% of all African American patients have high blood pressure. They also tend to develop hypertension earlier in life. And also African American patients tend to be more increased sensitively to sodium or have increased sensitivity to sodium. And of course, with more sodium, the increased risk of developing high blood pressure. African American patients may respond differently to some blood pressure medications, and they may have a higher rate of complications from high blood pressure. And also, I'd like to mention our Latinx population as well too. 25% of all patients have high blood pressure, the Latinx population, and they're more likely to have high blood pressure and be unaware. And also they're more likely to have challenges establishing care with healthcare professionals. And they also have a higher risk of heart disease as well. And there can be differences how we manage these patients. For example, African-American patients tend to require more blood medications at a time to meet their blood pressure goals compared to other races. It can be more difficult to manage in African-American patients.
Thank you for sharing that. And I want to, at this time, I want to invite participants to drop your questions in the chat if you have those, because we will take your questions a little bit later on, but we will take questions from our audience, and we invite you to do that at this time. And so I want to bring Dr. Taylor into this conversation, because Dr. Taylor, I understand that you, in your practice, you are also taking care of patients with blood clots. Can you tell us, and blood clots have become a big part of the conversation lately, and if you can tell us how that connects, or how that connects with heart disease.
Yeah, so when I was working in the anticoagulation clinic at University Medical Center, I would often see patients who presented with atrial fibrillation, which is a disorder where patients have very rapid, uncontrolled heart rates. It's something that we see that increases in prevalence as patients age. I also would see patients who presented with cardiac valvular disease. So these are patients who presented initially with either stenosis or regurgitation in one of the valves. And so that had to be replaced. And after that happens, the patient would require lifelong anticoagulation, usually with warfarin. And then we also saw patients who had heart failure. And so these are some of the common things that we saw in the patients that I used to serve at University Medical Center.
Wow. And we're in carnival season in New Orleans. It's Mardi Gras. There are parties, great tasting food. You know, everybody's having a great time. So, and so I know that everything, some things we can mitigate, other things maybe not so much. But one of the things I noticed about each of your practices, and I've had the great pleasure of working with you all for a number of years, and in our conversations, there's some things I did not know. For example, that each of you has calculators that are restricted to healthcare providers that you use to predict patient outcomes. And so, Dr. Gillard, I'm going to start with you. And as you're talking about these calculators, I'd like you to tell the audience about what you're capturing and things that are innate, but also how one can take that, mitigate things.
Sure. In the management of cardiovascular disease, it's very important to identify risk factors very early on before patients are diagnosed with hypertension or heart failure or have a myocardial infarction. And indeed, some patients have inherent risk before they have those. So there is something called a cardiac risk calculator that us healthcare professionals use. And that calculator looks at, it's based on many years of data, based on certain races of patients and their risk of how these patients got certain disease states that develop myocardial infarction, hypertension, and so forth. There may be risks associated with it. So for example, there's a 10-year cardiac risk calculator that we use pretty frequently that I use in my practice that looks at certain factors that put patients at risk for cardiac disease, such as race, age, also gender, also cholesterol levels, how high or how low your cholesterol levels are, in addition to if the patient has hypertension, and also if they have diabetes, and also if they're a smoker. So these different factors can all be put into a calculator, and I can determine what is their 10-year risk of having a cardiac event or a serious cardiac event, such as a heart attack or stroke. And if their risk is high enough, that allows us to manage their disease states very aggressively. For example, based on that cardiac risk score, I may decide as a healthcare professional, my patient needs to be on a medication to lower their cholesterol levels, or my patient may need more aggressive blood pressure lowering therapy based on how their risks are. So that's called a cardiac risk calculator that healthcare professionals use.
Thank you for explaining that to me and to the audience. It's really important to know. So Dr. Gillard, let me ask this question. How important is knowing one's family medical history? How does that play a role in this calculator prediction of risk?
Oh, it's extremely important. So there are definitely a link between family history and things like heart attack risk. A family history of heart disease is generally defined as one or more of the following, one of them being first-degree relatives that have had a heart attack before. So for example, if a family member has a mother or a sister or a father or brother that had a heart attack at an early age, before the age of 55 or before the age of 65, that is considered pretty significant cardiac risk. So being aware of that family history is important and should be discussed with their cardiologist or their primary care physician. Now, we know that family history is a non-modifiable risk factor. We cannot change our family background, but it's very important to be aware of it so physicians can appropriately manage or reduce the risk of having a serious cardiac event.
Thank you for that, Dr. Gillard. That is really insightful. And Dr. Taylor, I know in your practice, you also use a calculator. Can you tell, for healthcare providers use this calculator? And so can you tell us more about what exactly you're using the calculator for? And also give some insight on how patients might be able to improve their overall health outcomes if they better understand some of those factors.
Sure. So when we're using warfarin, which is the predominant anticoagulant that we used in my clinic, we really want to know what a patient's bleeding risk is, because this drug specifically is designed to thin the blood, and that causes the patient to have a higher bleeding risk. And so the tool that we typically use was called the HASBLED, which is HASBLED. And it's an acronym that stands for some of the major factors that are associated with bleeding risk in patients who are receiving anticoagulants, particularly patients who have atrial fibrillation. So we would use this score to determine what's the patient's risk for a bleed within the year after initiating the anticoagulant. It also can be helpful for determining how closely these patients need to be monitored if they actually have a higher risk. So it consists of some clinical characteristics that are usually going to be seen in specific patients. So patients who have uncontrolled blood pressure, so their top reading, their systolic blood pressure, if it's greater than 160, that is considered to be 1 point. If the patient has kidney disease or if they have liver disease, that's going to be 1 point for each of those. If the patient has had a stroke in the past, or if the patient has a high risk of bleeding, then that also would give them 1 additional point for each. If a patient has been on warfarin in the past and they have not been able to get into a therapeutic range, then that also would increase the risk. That would be a 1 additional point awarded. Our elderly patients are usually the most sensitive to these medications. And so if you're considered elderly or over the age of 65, that's an additional risk. And then lastly, patients who are consuming alcohol, if they're having over 8 drinks a week, or if they're using medications concomitantly with warfarin, specifically antiplatelet medications like aspirin, or over-the-counter analgesics like NSAIDs, then those are things that would also increase the risk. So we would look at all of these specific characteristics for each patient and award the points. And patients with a score higher than 3 would be patients who we would be most concerned about initiating an oral anticoagulant.
Thank you for explaining that so well, both of my colleagues. Thank you so much. I see that I want to talk a little bit about, each of you mentioned some things that are innate, and I'm also hearing you say, knowing my family medical history can also help me better manage myself, and be aware of these predictors. Can you say a little bit more about nutrition? What is it that we can say? So there's some things we can control, but there's some things and some things we can't. But kind of what we eat, that can kind of mitigate some, or it can help or hurt us. So can you tell us more? And I'm going to start with you, Dr. Till.
Yes, so warfarin itself, the way the drug works, it basically inhibits clotting factors, which are made by our liver. Okay, so these clotting factors are dependent on vitamin K, which is going to be found in many of the foods that our patients consume. So if patients are eating foods that are rich in vitamin K, it works against the warfarin, and that requires higher dosing of the medication. It also requires usually more frequent visits to the clinic to check the patient's levels. So we spend a significant amount of time counseling our patients on keeping their diet steady. We don't like to tell patients what foods they can enjoy, but we do want them to be consistent in their consumption of foods that are rich in vitamin K, because if they are modifying frequently their consumption, then that can make the medication less effective, which would increase their risk for having harmful clots. And if they were to stop taking the vitamin K in the diet, then that also would increase their risk for bleeding. So we spend a substantial amount of time counseling patients on how diet impacts their warfarin level, and it can potentially increase their risk for bleeding of clotting if they're not consistent with their consumption of vitamin K rich foods.
Thank you, Dr. Taylor. I'll ask the same question to Dr. Gillard with respect to the patients that you care for. Are there any special dietary concerns that they should be aware of?
Sure, absolutely. When we talk about hypertension and also preventing heart attacks, lifestyle changes are as important as medication therapy. So one thing we target the most of is sodium intake. So reducing sodium is extremely important. And one thing we use is a diet that's rich in fruits and vegetables and low in sodium. It's one of the things we do emphasize going forward with lifestyle changes. Also portion sizes. So, and also reduction in saturated fat intake. Well, some patients will discuss, staying away from certain products, but also portion size. So when we think about the plate, one way we discuss with patients is the plate method. So when we think about or visualize a plate, actually, as far as the meat or protein should only be a fourth of a plate. And most of the plate should be very little in grains and also very rich in vegetables. That's one thing we target very much in our patients with cardiac disease. And although family history is not modifiable, we can offset those risks of family risk with healthy lifestyle modifications like diet. So the plate method and also reducing sodium intake are very important.
Thank you, Dr. Gillard. And so this is this is real. And here in New Orleans, I'm not a native of Louisiana, but one of the things I love is the cuisine. And I've had to learn how to modify and manage myself where the folks here love flavor. One of the things that I know that and I'm assuming that each of your healthcare teams offers guidance to your patients with respect to preparing foods where you don't lose the flavor, but you modify the foods in such a way that they are now heart healthy. Are there any tips or any guidance that either of you can offer to your patients with respect to a heart healthy or a site or somewhere they can go for heart healthy foods?
Yeah, so when I'm working with patients who have hypertension, patients who have heart failure, patients who are salt sensitive, I typically encourage them to limit their consumption of processed foods. So these are going to be items that are purchased that are in a can, in a box, in a bag. Those are the foods that are going to increase their blood pressure more than likely in the most significant way. So when we talk about shopping and how we can make smarter choices, I typically tell the patient that they want to spend the bulk of their time in the supermarket in the perimeter of the supermarket. So every grocery store essentially looks the same. When you walk in, you're going to see the fresh produce. As you make your way around the store, you're going to see the meat section, okay? And then in the back of the store is the dairy. If they're spending the bulk of their time there, more than likely they're going to have a heart healthy diet. Everything that's in the middle of the store is heavily processed. These are going to be our boxes of foods, our bags of foods, our cans of food. So just thinking about shopping in that way is helpful, because many of my patients tell me if these items are not in their homes, they won't eat them. So if we're thinking of this as we're shopping, then less likely these things will make their way into our home. I also encourage them to limit their consumption of fast food, because that's something that is heavily processed. Many of the patients who consume these things, they think that it's, least expensive way to eat. And it may be not expensive right now because you're not paying a lot for the food, but you're going to pay for that later with your health. And so, always reminding of them of these things when they engage with us is what we encourage. in order to follow a heart healthy diet. Dr. Gillard?
I would definitely agree with Dr. Taylor. One thing I would say is that, compared to when you're going out to get food, you have control when you're fixing your own meals more. So we know restaurant foods or fast foods are very well seasoned and have a lot of sodium for the taste. Well, when you're home, there are some small changes you can make. There are salt substitutes. There are things we can use that may be more appropriate seasonings to reduce the amount of salt intake. Also, baking things or broiling things may be a better choice, more lean meats. Those are things that can be more easily done compared to restaurants or fast food. Not to say that, that can be completely eliminated, but you want to reduce that intake of fast food and restaurant food will be the biggest target. And also cholesterol as well. So more grains, more oatmeal, or more cereals that are high in fiber can reduce the amount of cholesterol that is in our day-to-day practice.
Thank you, Dr. Gillard and Dr. Taylor. That is rich information. And from the activity in the chat and the comments in the chat that I'm also seeing, there's been a rich dialogue that's going on there. I will lift out in part one of the questions that is here from one of our veterans who is in the call, who mentions that they have a genetic issue as it relates to cholesterol, and actually actively going to the VA and participating in programming there. Is there anything that you would add for any comments that either of you want to make with respect to patients who may have a genetic association to high cholesterol as it relates to heart disease?
So I would encourage her to speak with her physician, because we have some wonderful new medications that can be used specifically for patients who have these genetic conditions that increases their cholesterol. For most patients, we typically start off with a class of medication called statins. Most patients do well with those, but again, she'll have to speak with her doctor. And then we also have some new injectable medications targeted specifically for those patients who have these genetic conditions. In terms of what she can do herself, the biggest, I think, culprit is going to be fried foods. So looking at her fat consumption in her diet, reviewing a nutrition facts label. I'm certain that they'll do that in the class that she attends. And so she can see what is the fat, what is the fat in the serving of food that she's eating. And then also knowing specifically what a serving is. Sometimes we mindlessly eat. And so just knowing specifically, measuring out what that serving is before you sit down and eat on something, and just trying to limit your consumption of fried foods. That's the biggest culprit with lipids.
One of the questions I got in the chat, and this will go to either Dr. Gillard or to Dr. Taylor, it asked if using an air fryer would be considered a heart healthy approach to avoid or to minimize fats in one's diet.
That is a great question. Regarding the air fryer, yes, that will be beneficial because you're not cooking the product in saturated fat or oils. But it's also you have to be mindful what products you're eating in the air fryer. For example, if you're eating frozen chicken tenders, are you going to warm those in the air fryer? Well, it's breaded, and also there's a lot of salt in there itself as well. So you want to really be mindful of the product you're using in the air fryer, but there is a benefit because you're not cooking it in saturated oils. Dr. Taylor?
I agree, Dr. Gillard. It really depends on what you're preparing in your air fryer. It is a tool that we can use to limit the fried foods, but if you're still using unhealthy items in that device, then you're still going to be getting in substantial amounts of fat. So you want to just know, what are you eating, as opposed to how you're preparing it. What you're eating is very important.
I also see a question in the chat with respect to the role of certain hormones. And certainly we know that insulin is a hormone. It's also it's a peptide hormone that plays a substantial role in diabetes. Would either of you care to make mention of the role of hormones with respect to heart disease? And in the comment, several things are mentioned, but I will speak to, and we can speak to insulin because it's a rather complex question. I know we don't have time to address it in its entirety.
So I'll speak to that. Insulin is a hormone, and it's one that is life-saving for patients who are not able to make the insulin that they need for their bodies, or patients who are not able to fully utilize the insulin that they do make. I work with diabetic patients almost daily at the VA hospital, and I always try to teach my patients how to use insulin as a tool to make sure that we're able to get the energy from the foods that we eat. Trying to keep as much insulin off of the patient as possible, just enough to keep the patient's blood glucose control, because patients who are using large amounts of insulin, it is something that we know can actually increase the patient's appetite and can contribute to weight gain. So finding that balance with how much is needed, and then also thinking about other factors that can increase blood glucose, like your foods that you're eating and the things that you're drinking. So I think insulin can be something that is useful. It is useful for most of the diabetic patients. And I hope that answers that question.
Thank you. I see another question in the chat that is asked. How substantial are the benefits of cooking using oils such as avocado oil as opposed to other fats such as margarine and butter, the short and long-term benefits? Or do you have an alternative that you would recommend as opposed to using either of those items?
There could be some benefits of using some products such as avocado or olive oil, but I would refer that question in relation to that question to the nutrition facts label. So there should be a direct comparison about what does avocado oil have as far as saturated fat or trans fat as compared to what does regular oil have. And, you know, when we are in the supermarket, we definitely want to check the back of that product. So the front of the product makes the product look very interesting to us as a consumer, but the back gives the information. So we want to compare the saturated fat in those products to see if there's actual benefit. I think that would be the biggest step to take.
Okay, thank you, Dr. Gillard. I have a couple of other questions that are in the Q&A, and I'm going to read that. I'll ask either you or Dr. Taylor to take this question. Is an electronic medical record with an accompanying portal used to capture the data and share insight and information with the patient?
So the portal is a great way for patients to be able to see their most updated information in regards to labs, their current medication list, their conditions. It's also a great way for patients to communicate directly with their provider if they're having questions or they need anything from their provider. So I think it is a very helpful tool, especially if we have patients who are not getting all of their care in one place. They're able to share this information with providers typically outside of their network. And then they're also able to keep up with changes that they may see from one visit to the other in regards to their medications and their labs.
I would agree with Dr. Taylor as well. It can be a good way to keep up with your health information, especially if you're a caregiver and if you have the consent or permission from that patient to keep in touch with those labs. So for example, my parents, you know, I have access to the health portals and I can ask questions to the physician or keep up with their lab data, especially when I can make it to their doctor's appointments all the times to keep up with where they are in their certain disease state. So I think it can be very beneficial to keep up with your information in the health portal.
Dr. Gillard and Dr. Taylor, what I would like to do is, I know that you mentioned early on, and we answered most of the questions, all of the questions that were in the chat and in the Q&A. Yes, we did. And so what I'd like to do is, as we are thinking about things, are there any specific pharmacogenomic recommendations with respect to each of your professions? So is there a known genetic variant associated with certain populations with a particular classification of medications that makes certain patients benefit more therapeutically than others? And if we could say that and clearly kind of indicate that, that would be helpful. Take Dr. Gillard, I'll ask you to go first.
Sure. Actually, there are some genomic or genetic or pharmacogenomics things linked to cardiovascular disease. Well, I'll start with hypertension first. There are several different blood pressure medications available that we use to treat high blood pressure. Well, when we think about one class, one common blood pressure medication class are ACE inhibitors. And anybody that has hypertension, there may be a medication is being used. So for example, lisinopril or nalopril or ramipril, those are common blood pressure medications and they work really well. But some patients may have a different response to this medication. For example, African Americans, because African Americans are more sensitive to salt, they may have a reduced or blunted effect with ACE inhibitors. And actually, the study did show that does exist. And for that reason, African American patients tend to require not one, but maybe even two blood pressure medications to reach their blood pressure goals. So that's one example. It doesn't mean ACE inhibitors do not work. They're very effective, but some patients may have a different response. Also, antiplatelet drugs are drugs that thin the blood. One example is clopidogrel, which is a drug we use usually right after a heart attack to reduce the risk of a second heart attack from happening. As far as genomics is concerned, some patients may have a different response to clopidogrel. Some patients may have a reduced effect from it. Some patients may have an over effect from it. And it depends on race and some other factors. For example, there can be some differences based on Caucasian patients, Asian patients, and also African Americans. Maybe African Americans have about a 25% response rate, a lower response rate with their medication. So what do? We should be aware that that does exist. And if there is evidence that that medication is not working as effective, that may indicate to our cardiologists there may need to be a change or an adjustment to the medication.
Thank you, Dr. Gillard. Dr. Taylor, same question.
So when patients are at risk for harmful clots, if patients have had harmful clots, clots in the legs, clots in the lungs, heart attacks, strokes, these are patients who usually are candidates for blood thinners. Warfarin, even though it's a very old drug, it is still the #1 oral blood thinner that's prescribed. Every year, about 2 million patients receive prescriptions for warfarin, and about maybe 35 to 45,000 of those patients actually end up in the hospital with some type of drug-related event. And our major concern is bleeding. And so what we've learned is that certain groups of patients have a higher risk for bleeding. Up to 20% of African Americans will have some genetic mutations that impact the way they metabolize warfarin, and it impacts their sensitivity to warfarin. So what does this mean? As a provider, I'm looking at how much do I need to reduce the dose of the medication to a patient who has these genetic variants. So this is something that I would really recommend and encourage patients to speak with their doctors about, especially if they've used warfarin in the past and they had a bleeding event, or if the patients have been having trouble figuring out what dose of warfarin that they should be on long-term or their maintenance dose. This may be a worthwhile conversation to see if those are patients who actually do have those genetic mutations.
I want to thank both Dr. Taylor and Dr. Gillard for their thoughtful input to this conversation in helping our participants on the call to have better heart health, knowing their ancestry, their heart health, and learning about the ALLofUS research program. So I want to thank you both. At this time, I'm going to ask Dr. Lucio Male from LSU Health Sciences Center to come forward and to share his call to action.
Thank you so much, Dr. Lemieux. The session so far has been absolutely outstanding. A lot of useful information, great questions. Before I go over my one slide, there's two things that struck me. The reference to family history. Family history is extremely important. It's not often taken well during medical examinations. Now, what that might mean, it could flag a genetic risk. If your parents or your grandparents or numerous people in your family are affected by a particular condition, there may be a genetic risk factor that would have to be identified. For example, I have high blood pressure, and my grandmother, 2 uncles, and my mother have high blood pressure. I'm pretty sure this is genetic. I was never tested for it. So when the time came to choose what medication I should be put on, it was done by trial and error. And the first 2 or 3 trials didn't work. They either caused relatively rare adverse events or were ineffective. Now, we can't always afford to do that. And the other one was a reference to diet and nutrition. I wanted to share with you that ALLofUS is starting its first major sub-study, and it's called Nutrition for Precision Health. And it will incorporate both surveys on diet and dietary environment, but also a smaller study of how individuals respond to 3 different types of diets that are prepared by metabolism experts at Pennington. So you all know that physicians and pharmacists are in their professions to heal. What we want to do is what I was taught when I was training, is to give each patient the right medication. Well, the right medication is the right dose of the right drug given to the right patient at the right time. And I don't need to repeat that patients differ in so many ways. But the more information we have, the better we can choose whether, when, or how much of which medication to prescribe, or what kind of dietary recommendations we may have. We've heard about warfarin. Here's a sad example from my own experience. When I was living in the Chicago area, I was actually at a horse farm, because that's my hobby. And one of the trainers was walking in front of me, and she suddenly collapsed. Everyone else froze. I jumped into action. I started CPR, called 911, and kept her alive as best as I could until the paramedics showed up. Unfortunately, she passed away several days later. What had happened is that this lady was on warfarin, and she was on an inadequate dose. She didn't have enough of it on board. She died because of it. So it's really important that we understand how each patient is going to respond to the medications and lifestyle adjustments. And that's the goal of the ALLofUS research program. There is a lot to share about what it entails to become part of ALLofUS, and I'm happy to answer any questions about it. You would want to email us at joinallofus@lsuhsc.edu, which is our dedicated email address, or call us at 504-568-5111. Look us up on Facebook as well. And if there's time, I'm happy to answer any questions in this setting as well. Thank you again for the invitation.
Thank you, Dr. Milay. Next, we're going to invite Dr. Takeda Ferguson to come up from the Alpha Beta Omega chapter of Alpha Kappa Alpha sorority. Dr. Ferguson.
Hello, everyone. Good afternoon. Yes, my name is Dr. Takeda Ferguson. The president of our chapter is Ms. Treve Profis. And we are so glad that you joined us today. We want to thank you all for attending this great health information seminar, My Ancestry and My Health, during Health Month. We are giving away some door prizes to some attendees. We've achieved 5 winners from our audience to show you just thank you, and of course wanting you to keep tuning into your health. We've chosen the 5, kind of some at random, but we're also going to reward the first individual that logged in today, and the 7th person who logged into the webinar, and the first person who posted a question for the panelists or to the webinar. And like I said, the other 2 will be given at random. So we will identify 5 winners. You'll receive your electronic gift card to Walmart or to Target within the next 2 hours. It'll be sent to your email that you use when you for the seminar. Again, thank you, and hope you learned or reflected on something today that leads you to improving your health. Thank you and be well.
Thank you, Dr. Ferguson, and thank you to our audience. We wanted to invite you to our next event, which will be on this Saturday, February the 12th at 10 a.m., where we have a talk working on heart health. So inspiring stories on heart health. And so when you show up for that, when you're actually going to do some movement, so you want to have some comfortable clothing on, because the speakers there are going to encourage us to move for our heart health. Lastly, we're going to ask that you would click on the link in the chat to complete our post survey. We appreciate your participation and you showing up. At this time, I'm going to invite Ms. Stephanie Marshall from DePaul to please come up and give comments on behalf of DePaul Community Healthcare Centers. Ms. Marshall. Ms. Marshall. Okay, Ms. Marshall must not have been able to stay on the call, but they are a partner. DePaul Community Healthcare Centers are a partner with the 7-Star Academy Incorporated in our effort to educate the community about the ALLofUS research program. So we want to thank them for their support and their participation. And we want to thank you, our audience, for showing up and for your thoughtful and insightful questions. So stay tuned. We hope to see you again on Saturday. So until then, take care and take good care of your heart.